Hello, everyone. I am Elliott-Goldschmid, and with my colleagues in the Lafayette String Quartet, I welcome you to the 16th Annual Lafayette Health Awareness Forum, navigating through COVID-19, using our collective wisdom to guide us. We acknowledge and respect the Lekwungen peoples on whose traditional territory the University of Victoria stands, and the Songhees, Esquimalt, and Wasanich peoples whose historical relationships with this land continues to this day. You are probably wondering why we are offering a health forum on COVID 2 years in a row. COVID hasn't left us. It is still affecting us. People are continuing to get sick. Important surgeries are being delayed because hospitals have an influx of patients coming in with COVID to be treated. We are still wearing masks to protect our friends, family, and especially our elders. And even though many of us have been vaccinated, this virus is still affecting us, each and every one of us. We're willing to let COVID go and move on. Unfortunately, COVID had other plans. It's wonderful that we have an audience here with us this year, as opposed to completely online last year. We are here in the University of Victoria's David Lamb Auditorium in Victoria, British Columbia, and there are many of you watching online. To all of you who are here with us tonight, we welcome you, and we're thrilled you're here. We have 4 marvelous speakers sharing their expertise with us this evening. They will be introduced to you very shortly. In order to attract these exceptional experts, we depend on the guidance of the amazing doctors on our steering committee. I would like to introduce you to them now. First, we have Al Hayashi, who is here with us in the room. Al, will you just wave to us? You all know Al. You're familiar with him. And then up on the screen, do we have up on the screen? No, we don't right now. Okay, but behind the scenes right now are our amazing other doctors. We've got Darlene Hamill, Marianne Blau, and Amita Modi. Oh yes, and Scott. Sorry, Scott. Yes, we. How could I forget you, Scott? Sorry. We also are extremely great. Well, hold on a sec. We've got. I was going to get to Scott. Sorry, just don't interrupt me. He's a doctor. He's just not one of the doctors. Okay. We are also extremely. I'm extremely grateful for our big mouth friend over here, Leah Potter, and her boss, Scott Hofer. There you go. At the Institute on Aging and Lifelong Health. They are wonderful partners to us, and we're so grateful to have them with us. We could not be putting on these forums without you. Thank you all. As is traditional with our forums, we would like to share a short musical welcome with you. Unfortunately, I will not be playing tonight. A couple of weeks ago, I had a bike accident on my way to work, fell off and fractured the proximal humerus of my left arm. The doctors all know where that is. And I am very grateful to my marvelous friend and colleague, David Stewart, for sitting in for me tonight. Thank you, David. We have chosen a piece which is part of a larger commissioning project that my colleagues and I have undertaken. We've invited 6 women composers from different regions all over the world to write new works for us. Tonight's opening piece is the final movement from a unique work written in collaboration between 2 BC composers, Nicole Mandrick and Leela Lustig. Leela is not able to be with us in person tonight, but we want to acknowledge, I don't think she's able to be here, but I just want us all to acknowledge that she is out there, and thank you, Leela. We're just thrilled with this piece that you and Nicole have composed together. The work is titled, We Will Remember Them. It is a beautiful, haunting song of remembrance, of honoring, and of loving our ancestors. And Nicole is singing this in her ancestral language of Anishinaabe. Thank you. That's amazingly touching music. I get a little taste of what you get to get every year. And it's a real privilege. Thank you. We were looking forward to having the honor of introducing to you our newly appointed music director, Dr. Alexis Luco. Unfortunately, just yesterday, she came down with some sort of bug and is not feeling well. She has 2 young children at home, and it's fall. Since staying home, if one isn't feeling well, is one of our best protections from the continued spread of the many flus and bugs out there, we support her decision, and we wish her a speedy recovery. And we really do wish you were here, Alexis. I think she's probably watching. So you are stuck with me as host tonight in her place. So there's a few housekeeping things that we have to do before the event actually begins. For our online audience tonight, your audio is muted, and the only video that is being seen are the presenters and me. This event is being recorded and will be posted to the websites of the Lafayette String Quartet and the Institute on Aging and Lifelong Health. So please tell your friends about this after. The presentations will be followed by a question and answer session involving all the panelists. During the presentations, if you have a question for a presenter, please add it, this is for online people, to the question and answer section of the webinar and indicate to which presenter you are addressing your question. You will see the question and answer button on the bottom of your screen, all right? Click it to bring up the text box. Questions will be moderated, and we will bring as many of your questions forward as possible to our presenters. Dr. Al will be our moderator for that part of the event. If you are here with us in person, please use slido.com, all right? Using the UVic guest Wi-Fi information in the insert in your program, log into the slido.com using the LHAF as the code. That's pretty easy to remember, Lafayette Health Awareness Forum, LHAF as the code. You can add your question to the Q&A section, the question and answer section at the bottom of that section, or in that section. It now gives me great pleasure to introduce our first presenter. Dr. Danuta Skowronski, isn't that a great name? Shouldn't she be a violinist with that name? Has led the Influenza and Emerging Respiratory Pathogens team at the British Columbia Centre for Disease Control for 20 years, where she informs surveillance, research, and program recommendations. Dr. Danuta is recognized for her emerging pathogen alerts, which played a pivotal role in 2003, you'll think back, to contain SARS-CoV-1 in BC before it could take off and spread as it did in the city of Toronto. More recently, in relation to SARS-CoV-2, which as we all know is COVID-19, her bold and broadly communicated recommendation to delay the second dose of vaccine has been considered, and I quote, the smartest thing Canada has done in this pandemic. Pretty cool, huh? Enabling more people to benefit as rapidly as possible from substantial single-dose protection. With 175 scientific publications, she is also credited with co-development of the test negative design, a methodology now being used globally to monitor COVID-19 vaccine effectiveness and the need for vaccine program adjustments going forward. Dr. Danuta's talk title is Vaccine Update.
Good evening, everybody. Can you hear me okay? Yep. Excellent. Well, I'm so happy to be here this evening, and it's such an honor. I have a lot of positive information that I want to share with you tonight, so much that we have to be grateful for in British Columbia. I'm going to try to compress it all within the 10 to 12 minutes that I've been allotted, but if I fail and my time runneth over, or even if I succeed and stay within time, I want you to know that available is a much lengthier, more detailed version spanning 50 minutes of what I'm going to say this evening. And you can access that at the BC CDC website in a grand rounds that I gave last week. But like I say, I'm going to try to capture the essential elements. And in fact, whenever my team does rapid response research, we typically try to distill the findings into a single summary slide for Dr. Henry to present during her regular media briefings. And so I have done that actually also with the most recent vaccine effectiveness update. And this infographic, this one-page infographic, you can also access on our BC CDC website. But I thought this would be a great way for me to organize myself and coordinate to try to stay within the allotted time frame given to me. So why don't I walk you through this infographic, and then maybe you'll be able to walk your friends and your family or others also through it, because there's a lot of great information, but it's quite crowded. So let's start with the title, shall we? I'm going to be then presenting the vaccine effectiveness of the 2 doses. And as background, I want to remind you how fortunate we are actually to be able to have such high 2-dose vaccine coverage in this province and in Canada. I'll just orient you to this slide. Along the x-axis is the week of the year of 2021. So week 1 would be the first week of January. And on the y-axis is the percentage of British Columbians who have received 2 doses of a SARS-CoV-2 or COVID-19 vaccine. You'll remember that in British Columbia, as elsewhere in Canada, we did make the bold decision to veer from the manufacturer's recommended schedule of 3 to 4 weeks between doses of COVID-19 vaccine to instead extend the interval to allow more people to benefit from substantial single-dose protection as soon as possible during that period of scarcity during the winter and spring period. And that decision was made in week 8. So the percentage of people who had received 2 doses in British Columbia stayed pretty constant at around 5% until week 22. And week 22 corresponds roughly with the end of May, beginning of June. And at that period, when vaccine supply was more abundant, we were able then to relax that recommendation to defer the 2nd dose and made it available within 8 weeks of the 1st dose, beginning in week 22. And then you can see there was a rapid rise. What a credit to British Columbians to see such a swift uptake in that offer of the 2nd dose, such that now more than 80% of adults, 70% of British Columbians of all ages recognizing that the very young children under 12 years of age are not yet eligible, but such a substantial proportion of our population have availed themselves of this vaccine. And I'll indicate to you why that is so important, given how protective these vaccines are. British Columbia then compares favorably in terms of 2-dose coverage to other provinces of Canada, notably our adjacent western provinces of Canada, comparable 2-dose coverage to eastern provinces of Canada, but overall in Canada about 70% have received 2 doses. And I want to underscore how privileged then we are in Canada compared to the rest of the world's population, where less than half, in fact, of the global population have been able to receive 2 doses compared to the 70% 2-dose coverage in Canada. But in particular, reflect on most of Africa, where in fact, not 1/3, but in fact less than 2% of the population of countries within that continent have been able to access 2 doses of vaccine. And in fact, less than 5% have been able to access yet even a single dose. I want you to keep that in mind when we are discussing calls for administering a additional third booster dose to the general population of Canada, and in particular, reflect on that when I reveal to you what the protection is with just even 2 doses of COVID-19 vaccine. So indeed, we should be feeling very grateful and privileged in this country to have access to these vaccines. And in fact, we have access to multiple COVID-19 vaccines, various formulations, including mRNA, messenger RNA formulations produced by Pfizer, the Comirnaty vaccine, as well as by Moderna Spikevax. We also have the adenovirus vectored vaccine produced by AstraZeneca, so-called Vaxzevria. And I'm going to be presenting to you then the vaccine effectiveness of those various vaccines, mix and match schedules in adults 18 years of age and older, excluding long-term care facility residents because they clearly have a different risk profile compared to the rest of the general population. We have used what's called the test negative design to do these vaccine effectiveness analyses. I don't have time to go into in detail how the test negative design is performed, but essentially it's a very simple and elegant design actually, whereby we compare vaccine coverage in those who test positive for SARS-CoV-2 compared to the vaccine coverage in those who test negative for SARS-CoV-2. And I do want to underscore how proud I am actually that this test negative design is a methodology that was first developed and pioneered by my team at the BC Centre for Disease Control to assess annual influenza vaccine effectiveness. And that methodology for influenza vaccine effectiveness was then rapidly picked up by the US CDC, the European CDC, multiple countries now in both hemispheres, as acknowledged in this publication in Lancet, and is now, I'm so proud, also being used for most of the studies that you are hearing about COVID-19 vaccine effectiveness. They're in fact using this made in Canada, in fact, made in British Columbia test negative design. So we have also obviously used it, and we are assessing vaccine effectiveness then from week 22, when coverage started to increase, the 2-dose coverage, to week 36, which is mid-September. We have just this week again updated the data download to the week 39, which is basically the first week of October, but I'll be presenting to you for the mid-September period. And it was during this period when we saw a rapid rise in the Delta variant, as you know, that more transmissible, potentially more severe variant. And about 90% of the case viruses included in the analysis that I'll be showing you were actually due to the Delta variant. We have nearly 250,000 specimens contributed by British Columbians in this analysis. So the first panel of the infographic is just to give you an idea of the participants, roughly equally male and female, with a population distribution reflecting both that of the general population in British Columbia and recognizing that young adults are disproportionately also contributing to the current 4th wave. But mostly I want to highlight for you the distribution of vaccines used by the participants included in this analysis. more than 90% of the vaccinated individuals had received an mRNA vaccine. Two-thirds, fully two-thirds, had received the Pfizer Comirnaty vaccine, about 15% the Moderna Spikevax, and then just under 10% had received that mix of either the Pfizer or the Moderna vaccine for their first or second dose. About 8% had received AstraZeneca, 3% had received both the first and the second dose as AstraZeneca, and 5% had received that mix and match of AstraZeneca followed by mRNA vaccine. So what did we find in terms of the protection? This is the key panel for you to focus on. And you can see then in these bar graphs, in blue is the protection that we observed against infection, the dark blue being any infection and the light blue representing just the Delta variant cases. And in orange, you see protection against hospitalization, the dark orange against hospitalization due to any SARS-CoV-2 virus, and the light orange against Delta. But the bottom line is that the two mRNA vaccines are providing more than 90% protection against infection including due to the Delta variant. Those who receive 2 doses of the AstraZeneca vaccine have lower protection against any infection, 70% compared to 90% for the mRNA vaccines. But notice that those who had received 1 dose of AstraZeneca followed by 1 dose of an mRNA vaccine had protection against infection, including Delta, that was comparable to those who received 2 doses of mRNA. And very importantly, note that regardless of which 2 vaccines, homologous, in other words, the same, or heterologous, in other words, mixed, different dose 1, dose 2, all of them provided about 95% protection against severe outcomes, notably hospitalization, including hospitalization due to the Delta variant. Well, what does this mean then for public health? The rough translation of a 90% vaccine effectiveness, well, what it means is that then for every 100 SARS-CoV-2 infections in unvaccinated people, 90 could be prevented through mRNA vaccination. But more than that, for every 100 COVID-19 hospitalizations in unvaccinated people, at least 95 were prevented through mRNA vaccination. And even if the AstraZeneca vaccine were somewhat less effective against infection, as shown here, still about 95 hospitalizations in unvaccinated people could have been prevented and were through AstraZeneca vaccination. I just want you to take a moment to think how deeply meaningful that protection is, not only in terms of preventing unnecessary suffering, but also in sustaining our critical healthcare capacity, particularly important as we are entering the fall and winter period of respiratory virus circulation. We have so much to be grateful in having the options, the availability of these vaccines in Canada. In the third panel of that infographic, what we were showing was, now remember, the bulk of the population has only in the last 4 months received their second doses since around the beginning of June. And since that time, across that period, we see no evidence of waning of protection, neither for infection nor against hospitalization, with, of course, prevention of hospitalization being the main goal of our immunization program. So up until we can measure it, we're still seeing sustained protection exceeding 80 to 90%, and we're continuing to monitor, including for the AstraZeneca recipients going forward. And that's why, as I say, we did another data refresh this week, and my team is busily working to assess to see if we see any signs of waning that would prompt reconsideration of additional doses. This is the crowning glory, I think, this fourth panel of the infographic. Let me orient you to it. It's basically showing vaccine protection, shown numerically here, by interval between the first and the second, here for illustration purposes, Pfizer Comirnaty dose. And again, most of our participants and most of British Columbians who have received 2 doses have received 2 of the Pfizer. But what is important to show here is that the vaccine protection exceeding 90% was greater when there was a longer interval between the first and the second dose, in particular for those who received their second dose more than 7 weeks after their first dose. For those who received their second dose less than 7 weeks, they still have substantial protection, but it is significantly lower than what was observed in those for whom a longer interval between first and second dose was applied. And although that might not seem like a big difference, I will highlight that a difference of 80% versus 90% corresponds to about a doubling in the likelihood of being a case amongst those who received their second dose less than compared to more than 7 weeks after their first dose. Now, for me, this is particularly gratifying because you may recall that there was substantial pushback when Canada announced that it would be extending the interval between first and second dose to enable more people to enjoy benefit from that substantial single dose protection. And I have to say, at the time that this storm was occurring, I was really scratching my head in wonder at even some experts questioning the wisdom of that decision. I can tell you that this is a recommendation that my colleague in Quebec, Gaston Dessert, and I actually formulated long back in mid-December. In fact, it followed the Pfizer submission to the FDA on February 10th. That was a Thursday. This is really emblazoned in my memory. On Friday, February 11th, Dr. Dessert and I discovered deep within that FDA submission by Pfizer, which was actually posted on the FDA website, on page 58, in fact, figure 13, that they actually provided information that showed that their vaccine efficacy was not the 50% that they were reporting for single dose, but rather more than 90%. And that is a real game changer when you're considering how to deploy scarce vaccine supply. And on that basis, with a more than 90% efficacy, we together made the recommendation to our respective ministries in mid-December to extend the interval between first and second dose. And we, in fact, on Christmas Eve, we submitted this letter to the editor of the New England Journal of Medicine, highlighting that it was really a matter of national security that the second dose be deferred. We showed our reanalyses of the Pfizer data, and we emphasized that there was little risk in doing this in terms of second dose response, especially given substantial first dose response, because in general, longer intervals between first and second doses typically result in higher and more durable antibody responses than shorter intervals. And so that, unfortunately, that letter to the editor, which we submitted Christmas Eve, was not published until February 26th. And it was thereafter that NACI on March 3rd made this recommendation to reinforce what we had recommended and to extend the interval between first and second doses, in fact, out to 16 weeks. And what we know now, in having analyzed the recent data, is that extending the interval between first and second doses not only provided more people with that substantial single dose protection sooner when it was most needed during the third wave in the spring, but it also optimized the second dose protection now that it is most needed against Delta during the fourth wave in the fall. And so this is the quote that our host cited then from Tristan Hopper in the National Post, highlighting that it was an important thing that Canada did. So what a difference a couple of months makes, right? This outrage in March, and then this recognition of the benefit of that decision 2 months later in May. So that is a walkthrough for you of this one-page infographic. And you can, again, visit our website to review the infographic, and also if you want to hear more in the 50-minute grand rounds that's also posted this there. And I want to close then by recognizing this brilliant group of women with whom I've been working very closely through the pandemic and who have been working on vaccine effectiveness so diligently behind the scenes. I want to bring them into the light and give them a chance for recognition for their very hard work. And that is really all I had to say, and I'll close there.
Wow, that's impressive. I'm going to go on that CDC website and I'm going to download that 50-minute presentation like now, right after this event. Holy cow. Thank you so much, Dr. Danuta. So proud to be from BC, eh? Isn't that incredible? Oh, wow. Just amazing. Now, we would like to have our next speaker come up. He's actually going to be speaking there. Dr. Jesse Greiner. Dr. Jesse Greiner is a general internal medicine specialist at St. Paul's Hospital in Vancouver, BC. He is the medical director of the Provincial Interdisciplinary Clinical Care Network's first post-COVID-19 recovery clinic at St. Paul's. It took me a while to say that, actually. I had to practice that a few times. He has worked to facilitate the implementation of the Integrated Research and Clinical Care Program designed to provide care to and learn from patients recovering from their COVID-19 illness. He has been extensively involved in the network's development of clinical care pathways and educational resources for patients with ongoing symptoms attributable to their COVID-19 illness. Dr. Jesse's talk is titled COVID-19, The Journey to Recovery.
Hi, can you guys hear me there? Can somebody give me a wave? Perfect, perfect. Thanks so much for giving me the illustrious opportunity to speak in front of you all today. It really is quite special. I'm hoping to talk a little bit today about my sort of journey looking after patients with long COVID. And here I have some objectives, things that I hope that we'll get out of this talk today. Talk a little bit about what long COVID is, what we know so far about this elusive illness. And then I'm hoping to bring it back at the end and talk a little bit about lessons that we can all take home in our own lives to sort of help with our own versions of our own wellness in this difficult time during the pandemic. I started every talk that I give with a disclaimer. This is a really new disease. It's actually like a quite uncomfortable thing for me to talk about. We usually go to medical school for 4 years. We go through training for anywhere from 2 to 5 years to become experts at what we do clinically, so that when we see patients in the clinic, we know exactly what we're talking about, and we know a whole bunch of information that we can use to provide care to patients that are suffering from their illnesses. And it's an uncomfortable place to be when a disease is a novel thing that I don't have years and years and years of experience to use to help my patients. So I've benefited as much from my patients, I think, as my patients have from me over the last year or two. So a lot of the information that's coming to us today is going to come from this domain of observational studies and a little bit of anecdotal evidence, and just some things that I've sort of noticed and that I've learned from my time in the COVID clinic. I really want to ground today's talk in this idea that there's like models of wellness that I think are important for us to realize. And the one that I've sort of focused on here is this idea that it's not just a physical wellness that we focus on, it's that there's physical, cognitive, and psychosocial or emotional wellness. And each of these domains is equally important when it comes to sort of a wholesome sense of wellness, right? Here's a sort of a pictorial diagram of a COVID-19 illness. On the y-axis of this graph is the viral load, and it helps sort of show the trajectory of the acute illness. On the x-axis here, down along the bottom, you can see the duration of time. And the important thing for this slide for me is this box on the right-hand side that shows there's a whole bunch of symptoms that patients experience in the sort of long-term or subacute period after their virus is long since cleared, that are really sort of multidisciplinary or multi-system. They affect multiple different areas of the body, and they can last a long time, sometimes weeks to months after the acute infection has long since passed. The information and the data around this in the literature is pretty difficult to interpret, I'll say. And this is still probably my favorite study. This is the COVID symptom study out of the UK that shows, and I believe that there's probably an exponential decreasing number or incidence of patients that continue to suffer with their symptoms as time goes on, which suggests that people in general are improving slowly over time. This number, this 2.5% of patients remaining symptomatic at 12 weeks has been really all over the map. I've seen numbers as high as 30%. And it's difficult because these are all observational studies, and how we ask the questions about a person's wellness can greatly impact the results that we get in terms of how well patients feel. We know there's specific risk factors for long COVID, and this is a very busy slide that's busy on purpose because there's so many physical or biological complications of the COVID-19 illness that we look for when you walk through our clinic, or when patients come through. We're looking for complications somewhere along this line, anywhere from myopericarditis to pulmonary embolisms and blood clots, organizing pneumonias, neuropathies, to interferon-1 defects and problems with immunology. That being said, these biological or physical manifestations that are easy for us to diagnose and classify, they really don't describe a huge amount of patients that continue to experience symptoms despite an inability for us to label them with a specific diagnosis. And so this is a study that was done, again, early on in the pandemic out in Italy, that suggested there's a huge number of symptoms that patients will continue to experience late on after their illness. This is a small number. There's some studies done by the Body Politic of patients that are also researchers that suggest there's somewhere in the range of 200 separate distinct symptoms that patients will experience that they have attributed to their COVID-19 illness. Okay, so it's a hugely variable syndrome that patients are going through. This is the sort of the story. This is when I see patients in my office, the story that I hear time and time again is that patients develop these variable yet personally distinct symptom milieux that wax and wane over time. It's a very episodic disease. The patients sometimes experience headaches. Some people it's brain fog and difficulty with thinking. Some people it's very, very physical. It's shortness of breath and chest pain and a runny nose and a sore throat, but wax and wane together over time. The symptoms seem to be exacerbated by stress. And by stress, I mean physical, cognitive, and emotional stress. So going for a long bike ride. For some people, it's walking up a flight of stairs. Cognitive stress, usually it's multitasking, it's complex problem solving, returning to work, and emotional and social stress, such as being in social interactions and engaging with lots of people. It's anxiety and depression, it's worry, it's anger, it's frustration. It's all of these emotions that we're all experiencing a lot during the pandemic. And interestingly, these symptom flares can be temporally dissociated for anywhere in the range of 24 to 72 hours post-stress. You can imagine how difficult that makes for the person that's experiencing these symptoms to directly connect to the stressor. So regularly in my clinic, I have to go through the sort of pattern with patients to help them see the pattern in their own symptoms. Anecdotally, the threshold at which the stress induces a flare improves over time if patients themselves are able to sort of pace their activities to put a lid on the stressors in their life and avoid these relapses. And the relapses, if they do occur, can actually worsen and lower the threshold for new relapses to occur. So it's really important to teach patients how to identify the physical, the cognitive, and the emotional stressors in their lives, to learn what that threshold is that's too much for them in this moment, so that they can bring the level of stress below that threshold and avoid these symptom flares and actually recover. What is it that's causing these symptoms? It's still unknown. There's a lot of theories out there, anywhere from endocrine and metabolic abnormalities in the mitochondria to hypothalamic dysfunction and neurologically mediated imbalances in your parasympathetic and sympathetic nervous system. And each of these theories have their own benefits and their own things that don't quite make sense. Where I started when I started on this journey is I started with this concept of reference class forecasting and looking at other places in the medical literature where similar syndromes seem to percolate and seem to exist. So there's this SARS and MERS sort of post-viral fatigue that actually we've seen in a lot of other viruses over the years. This post-ICU syndrome that patients experience after a critical illness, a post-concussion syndrome after people experience a traumatic brain injury, and then myalgic encephalitis. And if I were to line all of these illnesses up across the screen and create a list of all of the symptoms that patients experience in each of these illnesses, it would look something like this. And so what you instantly see is there's an incredible amount of commonality in each of these medical illnesses that helps me actually learn and start to understand what's going on with the patients with COVID-19. This is like a key slide for me. So where are we at so far? I'm going to bring us back to this model of wellness, this cognitive, psychosocial, or emotional, and physical wellness. And what I started to identify is that when any of these domains come under attack, under an excessive amount of stress, either physical, cognitive, or emotional stress, we start to see patients decompensate and they flare their symptoms. Whatever the cause is, their sort of level of unwellness, as you were, increases over time. So it becomes really important to identify and to help patients in the clinic manage the wellness in each of these three domains. And it's interesting because this sort of theory of these thresholds of stress that the body can tolerate, it percolates across all and a great variety of physiology that we learn about in med school. In the world of orthopedics and bones, there's a specific version of stress or a threshold of stress that the bones can tolerate before they experience a fracture. The same relationship exists in muscles, and we get tendon ruptures and muscle ruptures. The same thing exists in cerebral blood flow autoregulation, where there's a certain blood pressure that the vessels can tolerate before they're no longer able to control the amount of blood flow to the brain. The same thing is true, this is the Frank-Starling curve here on the far right, that there's a certain amount of pressure that the heart can tolerate before it just simply can't tolerate any more stress, and it starts to lose function and become weaker over time. So I think there's some important lessons that we can take from this concept that there's these thresholds of stress that we can tolerate, and if we move above those thresholds, we start to run into problems. In the clinic, so the most important thing in terms of management or helping these patients really comes from education and pattern recognition. It's showing patients and exploring the patient's journey, their illness, their idea of their illness, exploring that and looking at the physical, cognitive, and emotional stressors in each individual's life that's contributing to the reason why they continue to flare their symptoms, and helping them learn how to pace themselves so that they don't do too much. They really tone down the stress in their lives. And there's a lot of symptom and supportive management around pain, anxiety, insomnia, etc., that comes along with this. So if we were to pause for a second, and I talk to my patients a lot about this idea of plan, pace, and prioritize, right? As we try to sort of tone down the stress in our lives, we need to plan how our days are going to go. we need to pace ourselves, and we need to prioritize the important things in our lives, okay? And if I stop and I look at even regular people out there in the audience, people that aren't unwell with COVID-19, with myalgic encephalitis, with post-concussion syndromes, I think it's an important opportunity for us to take a step back and look at our own lives and try to understand where that threshold is, whether we are currently operating above that threshold or we're below that threshold, and to really take a look at this, because whether you're a patient that has significant anxiety and there's an incredible amount of emotional or psychosocial stress that goes along with living in the pandemic, or whether you're a single mom and you're looking after a bunch of kids and you're not sleeping, there's a whole bunch of illness and unwellness that comes along with each of these sort of lifestyles, if you will. And so for the last slide here, I'm throwing up, again, this is the same symptoms, but I've added one column on the far right, and this column I've titled Burnout, which is a relatively understudied, misunderstood concept in the world of medicine. But if I label all of the symptoms that people with burnout have, you start to see a very interesting, very similar relationship with all these other things. And this is where I think it becomes important, especially as healthcare providers. If you're a nurse that's working overtime in the ICU to keep people going, whether you're that single mom that's like not able to sleep, I think it's important to recognize where each of our thresholds are and to look for opportunities and ways to sort of bring ourselves below that level of threshold so that we're not burning out and that we're able to continue to provide for the society that we live in, to provide the services that we want to provide for the world long into the future. And that's the sort of take-home point for this whole topic.
Wow, Dr. Greiner, thank you. That was amazing. I was listening and thinking, I don't even have COVID, and I'm learning so much about my own life. And thank you so much. I also discovered that I went past my safe elastic stage. Did you notice that little bone thing? Now I know what I did. So I just want to remind everybody to please be writing down questions as we go along here. Keep in mind that you've got Slido for you guys here who are in the audience. Please use it. I'm sure the questions are coming. I'm certainly writing a whole bunch down myself. And for those of you who are online, it's at the bottom of the screen. All right, so please keep those questions coming. And now I'd like to introduce Shannon, who's here with us. Lovely. So Dr. Shannon McDonald is the Acting Chief Medical Officer at the First Nations Health Authority in BC. She is proudly Métis Anishinaabe with deep roots in the Red River Valley of Manitoba and a trained physician with postgraduate medical training in community medicine and psychiatry. Dr. Shannon has worked for over 25 years in the area of Indigenous health with broad experience at multiple levels of healthcare service delivery and health administration in both provincial and federal contexts, which is absolutely necessary when you're dealing with First Nations health, isn't it? Before joining the FNHA 3 years ago, she served for 5 years as the Executive Director of Aboriginal Health at the Ministry of BC. Deeply committed to the principles of supporting capacity and community development as keys to improving health status among all people, Dr. Shannon recognizes and supports the strengths and aspirations of community-level stakeholders. She is married with 5 children, 2 wonderful grandchildren. Now 3 since this, well, that was quick. And 2 dogs. And lives here in Victoria, lucky us, with her husband. The title is The Impact on First Nations of the COVID Pandemic.
I'm not as old as I look. It's been a long 18 months. So I honor and respect my colleagues. I listened to Danuta and her technical brilliance that has really changed the picture of COVID in BC and the world. And I work with Danuta's team, the surveillance team that worked with me. We work together quite closely, and I'm always a student when she's around. And then we hear about clinical brilliance. And Jesse, what he's been able to bring to the table in a new and wonderful world of study, and bring his heart to the work is really important. Somebody asked me not too long ago what I did for a living. And I said, I change hearts and minds one at a time. That my job is about relational brilliance. And I have the technical background. We can do that. We can speak that language. But the important language that I speak is that of relationship. The First Nations Health Authority has only been around for 13 years. It came from a tripartite agreement with the federal government and the provincial government. And when I moved to BC 11 years ago, I came to be the chief negotiator on that agreement on behalf of the province. Previous to that, I had worked for the federal government. So I sat in a room as an Indigenous person looking at the worlds that I had worked in and known and tried to figure out a way to bring them together. It's been an exciting journey. It's been an evolution. But oh boy, all the training I'd had said, if I can raise 5 teenagers, should I be able to handle anything? And then came COVID. So this has been the most fascinating period of my career by far, but it's also making me think about retiring. So I need to be able to read that, but I can't do it that way. So collaboration as a pathway to success. A lot of people thought First Nations Health Authority wasn't going to be able to do this, that whatever capacity we had built over the last 13 years wouldn't be enough to deal with a pandemic. Thank you. And they were wrong. They were wrong not just because of the people that work for First Nations Health Authority or participate in the governance, but the real champions of this story are the people in communities. The community health workers, the nurses, the itinerant physicians and others that travel to and from community, and those that participate in the relationships with the regional health authority partners and their neighbors. Without those relationships, we would never have succeeded to the point that we did. We always have to remember that I work for First Nations. I don't work for the provincial system. I don't work for the federal system. My boss is that population of Indigenous people. Sometimes I forget about that. There's an ego thing that comes with medicine. It's part of the package. You get it with the white coat. But I remember an elder saying to me, it took us 500 years to get this sick. What makes you think you're going to be the one to change that? Okay, got it. And the contexts around which we work, we are federally funded primarily through Health Canada originally, and then it became Indigenous Services Canada, lumped into First Nations Inuit Health Branch. They fund a very different set of work than we have developed over time. Initially, it was on reserve only. That has changed. It was only primary care. That has changed. And what we have managed to do over time is to give a lot of the responsibility for the care in the community to the people that know that community best. So a big part of our role is capacity development using partly that federal money. The other money that comes into the organization is provincial money, but it's all in chunks. Our finance guys are brilliant because it always comes as a project or as a 3-year period of time, or the buzzwords of the day are primary care networks. So here's some money for primary care networks, but there's no money for the capital infrastructure that's required. There's no way to staff with people that have the capacity to do the work. That is all pieces that we pull together piecemeal from all of the other funding and structures that we have. Our partners in the regional health authorities, our relationship has changed. Initially, it was quite resistant. There was a, this is our stuff, and that's your stuff. This is our job, that's your job. It became very, very clear in COVID. One of the things that was developed provincially was a rural and remote framework initiative. And in each of the health authorities, there was a table of people that sat down who were the public health service providers for the health authorities. Every once in a while, Health Emergency Management BC, the folks from the ambulance folks, they were there too, because we had to talk to them about flying in helicopters at the crack of dawn in bad weather conditions to pick people up, and First Nations people themselves. We were there as facilitators, but that work was done in relationship at those tables, and that's how we got this done. And finally, I'll talk a little bit later about urban serving organizations. In BC, we have about 160,000 status or status eligible First Nations individuals who are on our client registry list, the First Nations client file. It's a complicated document that comes from the federal government, Indian Registry, the province, the Ministry of Health's registration and premium billing list, so we can link personal health numbers to get data. All of those things have had to come together, but we know more than 60% of those people don't live on reserve. And they have to be served in culturally safe and appropriate healthcare facilities and programs all across the province. So a big part of our job has been that relational piece around cultural safety and humility. It's about teaching our colleagues to be reflective, to be able to look in the mirror and understand that the structures in which they work were created to benefit a certain part of our community and not others. And I think it's been bluntly put in front of people around the residential school issues in the last little while. That people understand that structures that were basically genocidal have really changed. And then is anybody surprised when I go to talk about vaccination and community, people are going, well, I don't know if I trust this. I don't know if we're being experimented on, because that's happened in the past. We don't know if this is something that's good for us and it's going to keep us healthy as a community, as a nation. So it's a bit of a different world. So this gives you a sense of where we've been at. This is our data up until October 4th. Each of the bars is a different health authority, and you'll see that it's not the same everywhere we go. Vancouver Island has done really, really, really well for lots of different reasons. The community's really got engaged. Vancouver Island Health Authority has been amazing. But of the 203 communities, 53 of them are in the Northern Health Authority, which is the size of France. So we're talking about extreme distances, extreme isolation. And they were actually, when Danuta was talking about that first population of vulnerable people that got the vaccines first, we started vaccinating people in our 10 most isolated communities December 29th. Happy New Year. And then the second dose within those short parameters that were initially what was recommended. We are now seeing in some of those communities outbreak situations in fully vaccinated people. So there are lots of questions about why that might have been and if that short interval may have had something to do with that. The honest truth is we don't know. And that's one of the reasons we partner with smart people like Danuta. This is the epi curves. just to give you a sense of where we're at. I got this job. I'm the acting chief medical officer. The former chief took a 2-year secondment to the federal government, so it's still not really my job. He left March of 2020. Bye, see ya. Wonderful guy, working hard, but man, don't leave town. And then we saw several peaks. Like, it's not just 4, but there's several peaks on that list. And the scary part is right about there, middle of August, averaging 10 cases a day, less than 100 active cases through the province. Shannon decides she's going on holidays. Woohoo! First time in 18 months. And went to Winnipeg, saw my grandchildren, including the new one for the first time. Got back September long weekend to 256 cases the first day I was back. So something definitely changed. And Delta virus is part of that, but we don't know if it's all of that. This is part of it. This is our vaccination stats, again, by health authority. So we're not doing as well as the rest of the population. And that strong mistrust is part of that. We have the vaccine hesitant, so people not sure, gonna let everybody else in town get theirs first and see what happens, gonna wait until we know more, wait until there is permanent approval of these vaccines, all of those things. There are the people that were just too busy. They were working away from the community. They didn't have opportunities, whatever. And then we have the vaccine resistant. They are loud, they are proud, and they are very effective in undermining the confidence of people in their communities. Some of them are religious leaders who have told people that they have to trust in God and not a vaccine. People have choices, and my job is that relational piece. Everybody, this is not a mandatory vaccine for most people. And so my job is to talk to them and give them as much good information as I can, and talk to them about misinformation, where they get it, and what to trust and what not to trust, and how to tell the difference. It's a really tough thing to talk to people about. But we're still, 70 to 80% vaccinated. But most of that is the population over 60. We're kicking butt in the over 60 crowd. We've got 90%, 95% in some communities. Our 20 to 39-year-old group are about 50%. So we're having a very different conversation with them. Employers are helping with the new vaccine mandates. That's something that's definitely motivating people. The vaccine passport is both a motivator and something that's making people really angry about having to carry another government card that says who they are and what value they have. And if you've carried a status card around for your whole life, there's a very different meaning to that than most people. Oop. Whoa, wait a minute. So the First Nations as a priority, part of my job is to convince leadership to get on board. You may or may not know that most chiefs don't live in community. They may work in community part-time, but a lot of them have other jobs, because being a chief normally doesn't pay that well. Many of them are educated people, and they are involved in all kinds of things outside of their community. So we needed to talk to them. We needed to talk to the elders. We needed to talk to the trusted individuals and communities to be our vax champs. And if you want to see some of our Vax champs, it's great, fnha.ca. We have a piece of our website that people have taken pictures, getting their needles, talking about why they got their vaccine. Okay, this is when I know I'm old. We're actually starting to get influencers to be our Vax champs. And lately, one of them is a guy named Kiefer. And I'm like, who is Kiefer and what did he do? Apparently he was on Big Brother and he was a big hit among an age group that I don't belong to. Our healthcare providers, especially in our remote communities, many of them are itinerant. They come in and they go out for weeks at a time. We have a lot of agency nurses who are not as committed to the community as people who might live there. So we are constantly retraining people at the community level. And, you know, fnha.ca, I spend a lot of time. I had 9 media interviews in the last 2 days. So do a lot of work in communications. We have a very active communications team building our website. I have done so far 55 town halls in the last 4 months, and talking to people about all of the aspects of COVID and immunization, and self-determination, and all of the things that the nations are really interested in talking about. So this is just part of the list of gazillion meetings that are part of my job. And I was laughing with Matthew earlier to stay and be with people to celebrate this event later. I can't do that. I have a 5:30 tomorrow morning because our federal partners work in Ottawa. That's 3 hours away. And when they do an 8:30 morning meeting, it's 5:30 for me. So, but it gives us an opportunity to tell our story and build relationship with all of those people. So that's the expert in relationship thing. So regional health authorities and frontline partners. We didn't get our own supply of vaccine, except for those first 10 communities that we did starting in December 29th. Other than that, all of our immunization supply came through regional health authorities. Our vaccine supplies like needles and protective equipment and all of that came from the federal government. Our environmental health team became logistics specialists, and they were literally delivering that stuff in the back of their SUV, water taxis, small airplanes, and they were all over the province in situations they probably shouldn't have been traveling in. It reminded me of the Iditarod story, right? The dog race in Alaska, where, you know, you just got to get through no matter what. And so I really give them credit for that. I mentioned the remote and isolated framework. We built isolation supports in communities that had housing shortages. We literally flew in and barged in trailers so that we could have isolation locations. It's one thing in the south where you can send somebody to a hotel, but in some of these remote communities, there just isn't extra housing, and often 10, 12 people living in a house, so isolation was a challenge. And collaborative teams. So not only did we have health authority people at our clinics, we had our staff at health authority clinics to provide that cultural safety piece. We had elders volunteer to be there and walk nervous people through. It was quite wonderful. And that real-time notification pathway for case and contact management. That was new. Health authorities were really cranky about privacy legislation and how are we going to do this, and circle of care, so only registered health professionals could receive notification of a case in community, except we didn't have nurses in every community. So what were we going to do? So we had to build a notification pathway that works, and I receive every single COVID notification of a First Nations status person in the province every day. So that 24/7, 365 thing, yeah. So I talked about the frequent town halls and our website, lots of regional newsletters, and 24/7, 365. I now have 2 other public health docs working with me, thank God. So we share call. But for almost a year, I was on call every day. And finally, the urban serving organizations, and I really want to give credit to the BC Association of Aboriginal Friendship Centers, who opened their doors to clinics and made it happen and fed people, and were really wonderful being able to serve our population. And working with Métis Nation BC and the Métis chartered communities, allowing them the recognition and helping them build their own data system to monitor their populations. So it was really about access and cultural safety. Just a quick on unintended consequences. Isolation and loss of personal freedoms was big. It was big for all of us. I know I didn't see my grandchildren for 2 years, and it's really, really tough. And remembering in many of our communities, there's no long-term care facilities, so people were caring for elders at home. The economic impacts, job losses, many of the industrial camps just shut down, and those were major employers in the area. So we did a lot of work on food insecurity. We were those guys that were dropping off vaccine were also dropping off food supplies. Big negative effect on mental health. We've seen a huge demand, not only related to COVID, but then layer on top of that our toxic drug crisis, where we're heavily impacted in our communities, lots of losses. The residential school situation and what's come up in Kamloops, and wildfires and floods, and so the stressors have just layered on layer. I think the most important piece of this is the loss of culturally and personally important events. We're coming into winter ceremony season, and for many of the First Nations in BC, it's Longhouse time, where cultural ceremonies, people are named, welcoming children into the community. That's when funerals happen. That's when language is songs and drums are active and shared. And that hasn't been able to happen. And communities are craving that cultural and spiritual piece. And recovery planning. One of the things that we're dealing with is a sense of hopelessness right now, especially with the Delta variant numbers come up, that people are really discouraged. And so a big piece of this is keeping the energy up to get people to keep going and do the work. So that's me. That's my world. Thanks.
Thank you so much, Dr. Shannon. You know, I listen to you and I feel like we all have to be in this together. We've all learned a lot in this last few years, and we were just invited, we were as guests to the Klamath Nation this last summer up in Powell River, and they have one of the songwriters there gave the most beautiful analogy. We're all paddling in this canoe together, and I think I'm sincerely hoping that we all take heart from what we've heard tonight and join arms, link arms with our First Nations brothers and sisters and help, offer help, be allies, and stand with you. Thank you for sharing. The next person we have is Dr. Matthew Chow. Dr. Matthew Chow is president of Doctors of British Columbia. Doctors of British Columbia represents close to 15,000 physicians and medical trainees. I was thinking about that. That's 15,000 My colleagues and I, we're just 4, and we're having a tough time just getting organized. It's pretty impressive. Dr. Matthew is a Vancouver-based specialist in child and youth mental health and was one of the first in the province to adopt video-based mental health visits. He has contributed to new programs that serve vulnerable children, youth, and families. Prior to his election as President of Doctors of British Columbia, Dr. Matthew served in senior roles, including co-chair of the Specialist Services Committee, an Order and Council appointee to the Medical Services Commission of BC, where he helped oversee more than $3 billion worth of annual public health care spending. Dr. Matthew has witnessed firsthand the mental health impacts of the pandemic on his patients, on the wider community, and on his school-aged children. Dr. Matthew, your talk is on, sorry, I didn't write it down. I apologize. You're speaking about mental health in...
I'm probably speaking about
mental health in BC.
Pretty good bet.
Thank you.
All right. So I have a confession to make. And that confession is that the reason why I agreed to do this talk is because I haven't heard live music in 2 years. And so I came over, on the helijet to, and actually, how many of you, until today, how many of you had listened to live music before today? Yeah, just a few. They're all musicians. Oh, of course. All right. And thank you for that kind introduction. I am a parent to a small child. I think she might even be watching me right now. If she is, I want you to know that you should listen to mommy. Make sure you listen to mommy. All right, so I want to talk about COVID-19's impacts on mental health. And actually, I'm privileged because although I did not necessarily coordinate my talk with my colleagues, they set me up perfectly because they actually shared a lot of the points I think that will be salient in my talk. Bottom line is that COVID-19 has had a profound impact on our mental health. And if you look at Dr. Greiner's chart there, I kind of cringed a little bit when he showed that last column about burnout, because I was thinking to myself, I think I've had like 5 or 6 of those symptoms at some point during this pandemic. And almost everyone that I talk to in medical leadership, in politics, teachers, parents, they all tell me that they've had a lot of those symptoms. And so we're all kind of going through a collective something. Some people would say we're going through a collective trauma, a collective disruption, but something. We're definitely going through something together. And the data is there from the Canadian Mental Health Association, from the BC Centre for Disease Control, from the Sick Kids Hospital, and even more recently, I'd want to highlight something called the Youth Development Instrument that is administered to a sample of grade 11 students all across the province that showed a decline in mental health during the pandemic, an increase in alcohol use, an increase in substance use, increased number of overdoses. And there have been some disproportionately impacted groups: women, racialized people, young people, families with young children. And interestingly, these are groups actually that have struggled even before the pandemic. So there's something about this pandemic that's even exacerbated some inequalities and difficulties that we had previously. But I'll tell you, even the most high-performing people I know in my life have been affected at some point by this. There's no one that seems to be immune. So to some extent, I want to share with you that some of these symptoms that people experience, I hesitate to even call them symptoms. They're actually they seem to be part of this experience that we're going through, this pandemic. If I were to put one word on this, like if I were to label like what is the cause of this, I'd say that word is loss. Loss. And Shannon talked about it earlier. The loss of certainty, the loss of safety, the loss of security, the loss of autonomy, the ability to make our own decisions and go where we want and hang out with the people we want, the loss of social connections. And finally, something that's so important to human beings, the loss of ritual, the weddings, the funerals, the birthdays, the graduations, the new babies. These transitions in our life, these are actually really important parts of what make us human. and we have lost a lot of these. And what's interesting is that when we go through something like this, our response to this as human beings is to some extent actually genetically hardwired into us. So how we react to stress, how we react to a pandemic, to a large extent is actually baked into our genes. And it's also heavily influenced by where you grew up, with whom you grew up with, who took care of you when you were growing up, and what their philosophy of life was and their philosophy of parenting was, if you even had parents at all. And also, increasingly, what we're learning about is something called ACEs, A-C-E, adverse childhood experiences. So things like trauma, abuse, deprivation, even things like microaggressions. These adverse childhood experiences actually change who we are and change how we react to something like a global pandemic. And so broadly speaking, people, I kind of categorize people into these different scenarios about how they respond to something like this, and see if any of these ring a bell for you. So there are some folks who tend to turn inward when faced with a crisis that's overwhelming them, and I want to make that clear. We're talking about we're not talking about a little crisis. We're talking about big crisis, like a global pandemic. So some folks turn inward. They tend to kind of withdraw, close off a bit, seek safety, do a lot of introspection and reflection. And with kids, I'll see patients who become more anxious, a little bit more inhibited. They don't really want to participate. And, in internet culture, I'd call them the doom scrollers. See if you recognize some of that. On the other hand, I also run into folks that kind of turn out more. They become more irritable, angry, frustrated. They're seeking change. They're the activists. They want to change everything, their job, their relationships, political advocacy. And with kids, kids that become really frustrated and kind of rebel. I've heard stories of the teenagers that climb out the second-story window to go meet up with their boyfriend or girlfriend, even in the middle of public health restrictions. They're not following the rules. So it turns out that these kind of reactions, and I'm not saying that all human beings fit into these categories. It's a little bit too convenient to say that there's just two categories like that, but you can conceptualize it that way. In the midst of uncertainty, the key thing is that different people react differently, and that this isn't something that's abnormal. This is not an illness. This is not a defect, but it's actually about who we are. It's about how we grew up. It's about the influences that we had in our life. And so and this is especially pertinent to something like the COVID-19 pandemic, some people will want to move slowly. They will want to have certainty. They will want to see more data. They will want to be safe. And the others will want to move quickly. They will seek rapid action. They are intolerant of waiting. They want to move on. And the truth is, both are actually correct, because they're just who we are. It's just how we are as human beings. There's nothing objectively right or wrong necessarily about these different reactions. It's actually it's baked into us. It's even in our genes. But the problem is, I find this more and more in our increasingly polarized society, is that the folks that want slow and certain are sometimes cast as being anxious or being fear-mongers or being alarmist. And then the fast and impatient are sometimes cast as being callous or not caring about people's lives or just wanting to let the virus rip. But again, I want to emphasize that these are actually two sides of the same coin. They're both part of humanity, and they may be at different times, a little, more helpful or less helpful. For example, I have a friend that serves in the armed forces, and the first thing she did after she jumped out of a plane and landed on the ground safely is asked when she could go up again. So she's going to want to move quickly. I have another friend who has barely left their house in 18 months. Are either of them bad people? No. Actually, they're both my friends, both of these people. They're complete opposite ends of the spectrum. I love them and respect them both. They are just two sides of the same coin of humanity. But in the world today, we've become so polarized that we cast aspersions on each other and on the different ways that we react to the same crisis. So the title of my talk was to be, how do we grow from this? How do we grow from here? And so I'm going to make some proposals around this. But first off, I think we need to acknowledge that different people handle a crisis in different ways. We need to accept that that's the truth, and that there's nothing wrong with that. There's nothing wrong with that person. It's just the way that, it's how we grew up. It's what's in our genes. We can't change what's in our genes. This is just how we're made. And so the person who wants to go slow and be safe needs to understand that some folks want and need to move on. That does not make them bad people. But at the same time, the person that wants to move fast needs to understand that some folks need time. Time right now to reestablish safety, to reestablish security. And they will join everyone else in time. They're not just anxious, and they're not bad people. Again, just another part of humanity. And another part of growing from this is that we need to reestablish social connections. This is so important. This is one of the reasons why I came here today, to interact with people in the flesh, in person. Did you know, I've never met Dr. Shannon in person until today, right? And we're working in the same healthcare system in British Columbia. Although it is a pretty big, I have to admit, it's a pretty big province. But I mean, it's not that big, 5.5 million people. You know, that would be a small city in China, right? Actually, that'd probably be like a small town in China, right? But we just met now in person, even though I've met you on Zoom and even done a press conference with you one time together. And the other thing is we have to, you know, we cannot undermine and undervalue rituals. So those weddings and funerals and birthdays and graduations and special occasions that we put off, they're actually really critical. They're actually supremely critical because they bring us together. They're part of our culture. And so when we've lost them, it contributes to that deterioration in our mental health, that deterioration in our well-being. But the trouble in all this is that this pandemic restrictions, right, which are needed to save lives, but have also driven us online towards social media, towards endless days of Zoom calls, 10, 12 hours a day of Zoom calls. And the fact is that online social media, it's not the same as real life. It's not the same. And I'll tell you why. You've probably heard that there's someone that's testifying right now in the United States about Facebook. But this is not the first time that people have raised the alarm about social media companies. So we're learning now that the algorithms that govern social media favor controversy. They favor polarization. They favor conflict. Because it turns out that these are designed to take advantage of our psychological tendencies so that we keep coming back for more. It's a brain chemical called dopamine. It's part of our reward pathway in our brain. And we get a hit of dopamine every time we do something we enjoy. When we see something we like, when we're shopping, when we have a good conversation with somebody, when we use drugs, get hits of dopamine, and we get it too from social media. And so it's actually designed to take advantage of that. But unfortunately, in a way, and there's actually previous research that's shown that these AI algorithms, especially the early versions, contributed to more racism and hatred online. The algorithms actually contributed to hatred and racism. And in fact, they found that some of these algorithms actually learned racist and hateful terminology faster than they did more nuanced and welcoming and supportive terminology. So there's something wrong with these algorithms. And if you have any doubt about what I'm saying about the corrosive impact of social media during the pandemic, just ask Naomi Osaka or Simone Biles, two of the most accomplished female athletes, period, in world history, have basically found themselves bullied off of social media, have found that social media has destroyed or contributed to the destruction of their mental health, and perhaps in the one case, and now perhaps in both cases, the retirement from the sport at a very young age, far too soon. Or if you have any concern about what I'm saying about social media, ask any female politician or media person or anyone that's in the public spotlight. We also learned this week that Instagram knew that they contributed to eating disorders and suicidal thoughts in young people. Imagine if there was a substance, perhaps, I don't know, a virus, that contributed to people killing themselves or ending up in the hospital with a medical condition. We would probably institute some type of public health response to that, but that's actually happening with social media. So, you know, one of the best things we can do actually going forward is really rethink what we do with social media, our use of it, and also our children's use. I mean, my kids, I actually let them use a lot of screen time and play video games and things, but I actually watch their social media like a hawk because I know how corrosive it can be even for adult discourse. And then finally, in terms of how we move forward, and this goes back to what I was saying about my central thesis of that just different people have different ways of reacting to the same thing. I think we've learned from this pandemic we need to be more flexible. Society needs to be more flexible. And what I mean by that is things like in school, there needs to be different learning options, online, hybrid, different options. We've learned that some people actually do really well on online learning, but some really don't. And so we need the different options. In workplaces, we need people to be able to work from home. That's why 40 to 50% of people when surveyed say that they would quit their job right now if they were not offered the ability to work from home or to have that flexibility. That's huge. Job sharing, hybrid work. And finally, support for families, childcare, housing, because families really, really got hurt during this pandemic. And childcare was one of those things. I remember we lost all our childcare in the beginning, and I don't know how we survived those first couple months. My wife is also a healthcare worker, and I don't know how we made it through, but we did, but it was hard. So let's learn from this experience. You know, let's make society a bit more flexible, relationships more meaningful, discourse more civil, and let's just, in general, try to make things better than they were before.
Yeah. Wow. Rituals. I thought about that and how important they are. And for us and for me and my colleagues, this ritual, this health forum, it's an annual ritual for us. And it's this wonderful dance that we all do together with our committee and our doctors. And the next person I'm going to invite up to speak has been dancing with us for 16 plus years, Al Hayashi. Al is a surgeon with a fan base any musician in the world would envy, and he has been a member of our Health Forum Committee, and he was the inspiration, actually, for these forums since its inception over 16 years ago. Whether he likes it or not, he is an official part of our string quartet now, and we thank him for stepping in tonight to moderate your questions. Thanks.
So greetings, everybody, and I'd like to acknowledge the audience live here in the David Lamb Auditorium and those in cyberspace. I'm your friendly neighborhood surgeon, and I'm going to be moderating this question and answer period. Before we get started, I'd like to personally, and on behalf of all of those that have organized this meeting on the Health Awareness Forum, thank our guest speakers for taking the time out in their busy lives to present this evening at the forum for their excellent presentations and sage words. So thank you very much. You guys are all rock stars in your respective fields of expertise, so thank you. I want to just give everybody 2 minutes to stand up, stretch your legs and such. I know that a few of you older guys like me have bathroom questions in your mind, so I'll give you 2 minutes. And those in the virtual world to just run off and go and piddle as well. So we'll start in 2 minutes just to let you know, okay? So that we're not having any issues. And we have questions ready to go for all four panelists. Dr. McDonald and Dr. Chow are here, and Dr. Danuta and Dr. Jesse are online.
Lots and lots of copies. Can Danuta and Jesse see us?
Can you see us?
Danuta, Jesse, can you see us on stage here, or you can? All right, perfect.
I guess they see us through that camera.
Oh, through that camera there, okay, fantastic. All right, so once again, just for the sake of the audiences, those that are here, make sure you open your Slido app, and the password is LHAF, and ask your questions. It goes to the command center, which is across the street, and they curate the questions, and then they text it to me. And then those that are online in the virtual world, there's a question and answer box on your Zoom app as well, and so you can ask questions, and once again, it goes to the command center. And the way in which we will do things is when you ask your questions, please direct it to the panelist or panelists that you wish to ask a question to, and that way we can address that and hopefully get answers directly. So the first question that we will ask is to Dr. Shannon, if you don't mind me using your first names, because then I don't have to say Dr. Danuta's last name many times over. She's a rock star, I can tell you, but Pam Kibsey, who she knows and I know very well, she tried to coach me through how to say her last name today, and anyways, it's the Asian in me, I can't speak it. So Shannon, what are some of the ways do you believe the trust can be rebuilt around health issues for those who are in the First Nations Health Authority?
Wow, if you ever get the answer to that, let me know. I think it's going to take time. You know, going back to that elder speaking to me about it took us a long time to get where we are. But I think the important thing is to do your best to be an ally, to be self-reflective, to be aware, to ask questions, and to listen, really listen to the stories you're being told. One of the biggest complaints I hear from our population is that I went to the doctor, but I was only allowed to talk about one problem, and I have 17, and I had to travel halfway across the province to come to see the doctor, and now he's going to send me home and I didn't get what I needed. So in that patient's mind, they've been let down. The healthcare system failed them, and it's about transportation money, and it's about billing codes, and it's about a whole bunch of other things, and that's challenging. At the same time, my family doc has just announced her retirement, and I'm in panic mode. So many of the experiences we're talking about are universal, and being able to listen with empathy, and then not necessarily even offering solutions, but just listening.
Okay, thank you. Matthew, can you, some parents have held back their children from extracurricular activities, play dates, etc., due to this pandemic. As the pandemic shows no signs of abating anytime soon, how would you counsel these parents regarding what is best for their children's mental health, and I guess for their family, the family's mental health as well?
You know, oh, wow, that's a really good question.
In 2 minutes, please, less than 2 minutes.
Okay, yeah, not 20 minutes? Okay. I mean, you know, so I've talked to lots of parents about this. They're all across the spectrum. I mean, I'm a pretty risk-tolerant individual. I mean, my dad was in the armed forces, like we just did all sorts of stuff as kids that I, you know, did not want to repeat. And so I have a pretty high risk tolerance, but my wife, you know, has a different risk tolerance, and we've re-enrolled our kids into as much stuff as possible to normalize their experience as much as possible, because you know, my daughter is really a chipper person, but her mental health really visibly declined. She got really anxious and like closed off and stuff, and she was really, really lonely. And so we made that assessment that, you know, we need to get her back involved in stuff. But for different families, it's gonna be different. Like, you know, I talked to a colleague who, their kids, you know, a lot of childcare is provided by elderly grandparents that are immunocompromised. And so they have a different risk tolerance, and so they've chosen to still re-engage in activities, but, you know, on a more restrictive or more cautious basis. And I think, you know, both of those decisions are reasonable for that context, and we should respect that. I don't know if you have anything to contribute to that. What do you think?
I had 5 kids and no money. It was a moot point.
Touche.
All right, thank you. Question to Danuta. And these are 2 questions that are linked together, so I might as well just ask you both because these seem to be very popular questions. How difficult is it to design booster vaccinations because of the new variants that are coming up, including the Delta variant? And with regards to children and vaccinations, as you know, from the age of 5 to 12, firstly, why does it take so long to have them part of the conversation and such? And will the boosters be addressing the new variants that come up now and in the future?
Yeah, so currently the conversation is around giving additional doses of the existing vaccines with the existing original SARS-CoV-2 virus spike protein included. It is an underlying theory that the higher the antibody levels, also the more cross-reactive they are, the more protective they are against diverse variants that circulate. So even by using the same vaccine strain as was prepared months ago, giving an additional dose can boost the antibody levels to a high enough titer that they can better cross-protect against viruses that may be different from that original strain. However, we might get better protection still if we had a better so-called match between what is in the vaccine and what is circulating. We don't yet know if we're going to be entering a kind of schedule such as for influenza vaccine, where we're constantly chasing new variants and having to repeat boosters. However, so far, from the evidence that we've assembled, we're seeing that even 2 doses of the available vaccine strain is highly protective, even against the Delta variant. And there will be new variants as this virus tries to adapt further to its new host, us, the human population. There will be new variants. But so far, the vaccine is holding strong. And we have assessed vaccine protection now against Alpha. It held strong. Against Gamma, held strong. Against Delta, holding strong. So we just have to keep monitoring and to see how well it continues to protect against additional variants. For children, well, children weren't included in the original clinical trials, and as a matter of safety, prudence, we don't make assumptions that children are just little adults. They may respond differently in terms of both effectiveness and safety, and so we have to do the due diligence work of assessing that. We anticipate that the vaccines will work at least as well, perhaps better actually, in children, but we have to await that process of approval.
Thank you. Question to Jesse. Near the end of your talk, you spoke a little bit about burnout, and I don't know if it's known to the audience, but the healthcare teams, especially the ICU university departments, are just under huge amounts of stress, and there is significant burnout. So, Jesse, you're in that neighborhood as well. Can you just elaborate a little bit for the audience, because to provide some clarity, because you're right there in the front lines, and tell us a little bit about that.
Yeah. So I'm a general internal medicine physician, and when COVID came around, the burden of care, in the spotlight really did fall on the intensive care units, right? Because patients were being admitted to the ICU, and that kind of from an operational perspective was the linchpin or the bottleneck, right? In terms of what healthcare resources are required to look after patients, to help them recover. But that's really only part of the picture, right? So the general internal medicine physicians, at least around the greater part of Vancouver, have played a pretty huge instrumental role in managing and caring for the patients not sick enough yet to require intensive care, or still recovering from their intensive care experience and remaining in hospital often for months afterwards because of the severity of their acute illness through the ICU. So the healthcare system, you can kind of imagine, is a very efficient machine, right? There's not a lot of excess physicians, not a lot of excess dollars being spent on things. And so when a pandemic rolls around, there's not a lot of excess healthcare resources in terms of personnel that are just sitting there idly by waiting for the extra work, right? So all of the physicians that were working in on the clinical teaching units and the other places that they normally have their careers built have to pivot and actually increase the amount of work that they do just to manage the extra burden of illness that our society is now seeing. The burden of caring for people with long COVID, in my case, so my case is just a bit special because I was looking after COVID patients on the ward, but I'm also looking after the long COVID patients, plus the work that I was doing prior to all of this. So I think that I'm a little bit susceptible to this concept of burnout, just because the volume of work has become so tremendous that it's difficult to manage sometimes, just to be perfectly honest. And so when I bring it back to this concept of the physical, the cognitive, and the social wellness, just as a function of an overall state of health, when the cognitive load or the emotional load becomes so great, it can become difficult to continue to be a healthy, vibrant version of yourself, from a whole number of different reasons. And there are physical reasons, there are physical symptoms, there are psychiatric reasons and psychiatric symptoms. There's a whole bunch of things that start to happen. And I'm not totally sure what the underlying pathophysiology of this syndrome is, but we see it in time and time again. And there's models of it in this physiology that I talked about in my talk. It's very hypothetical. This is just stuff that I've been thinking a lot about over the last year as I see these patients sort of roll through my clinic and I reflect on my own experience. So I think that a lot of healthcare providers are going through a ton of cognitive strain by working a lot of overtime, often through the nights, looking after critically ill patients. So there's an incredible amount of cognitive burden that healthcare providers are undergoing. There's also an incredible amount of psychosocial or emotional burden, right? The protests that are protesting against vaccines and vaccine mandates, the patients picketing outside the hospital, and then having to walk into the hospital and seeing those same patients rolling through the ICU, becoming sick. It becomes a very difficult, emotional experience, right? And it's just a lot of stress that people are under. And I think that some of us maybe aren't as aware of the health impacts that has on us individually. I hope that answers the question to some degree.
Great, thank you. This is a general question perhaps for all four panelists to, from their perspective, maybe speak on. I'll start with Shannon. Can you address the misinformation issue and how you think it might be best addressed from your perspective with your group and cohort?
I haven't quite figured that out yet. We have a lot of conversations with people about the source of their information, helping them understand the need of peer-reviewed journals and other reliable scientific sources of information as having value. But culturally, for the population I serve, that's not the voice that is most valued. It comes from family, it comes from your elder, it comes from others. So those influencers I talked about don't all go on TV shows. Our big influencers are those elders who have accepted vaccine and have been a voice in community. But Matthew talked about social media and the dangers of social media for some people who are susceptible to those messages. It's really, really challenging. And I'm not sure I have the answer yet.
Matthew?
Yeah, I mean, social media, I mean, misinformation is killing people. Let me be really blunt about that. Misinformation has probably killed more people in Canada than bullets, bombs, missiles, and terrorism. Just over the past year and a half. I don't think I'm overstating it when I say that. There are patients that I've heard about who nearly die of COVID in the ICU because they're unvaccinated, and when they leave the hospital, still do not want to be vaccinated. And their families don't want to be vaccinated, and they hang out with other people that don't want to be vaccinated. There is something very, very wrong in this picture. And certainly there's social cultural elements to it, but I have to think that, you know, people are spending so much time online, so much time on the internet, and it is so polarized that I think it does contribute to this. You'll recall that after September 11th, 2001, the Western world spent trillions, basically, on security, wars, to fight terrorism. And perhaps I'm being a little bit provocative in saying this, but perhaps we need to make that kind of investment to fight misinformation because of how much damage it's actually done to our society and how long it has prolonged. And I really do think it has. Misinformation has prolonged this pandemic, has prolonged the suffering, has contributed to more deaths. When you think about the talent that we have in this province, like people like Danuta and Shannon and Jesse, and I'm just a schmuck, but you think about the talent we have in this province, and yet people still think that COVID doesn't exist. There are people in this province right now that believe that COVID does not exist. I think we need to fight that just as much as we fight terrorism or any other, you know, huge global threat.
Danuta, how do we address this cognitive dissonance?
Well, I think people respond. First of all, trust is hard earned. It takes years to build trust, and you can lose it so very quickly. And once it's gone, so difficult to rebuild. I try to approach people with whom I disagree about vaccination the way I approach people I disagree about other things. I try to be respectful, truthful, transparent. I try to speak from my area of expertise scientifically, and I hope that that makes an impact. I don't know that we can change minds overnight necessarily, but I think bit by bit we can get there. So that's my approach. I speak from the evidence, and I hope it has an impact. And I do believe people respond to authenticity and a sense that they are being heard. I think it's reasonable, in fact, to ask questions. I think it's fair. And then it's our job to do our utmost to address those questions, fill in the gaps for them. So that's the best that I can do.
Jesse?
Yeah, I mean, a lot has been said before me. It's definitely like a systemic issue, and social media plays a huge role in all of this. But I guess the only thing I have to add really is my own personal approach in the clinic. And I try to take an approach of, it's funny that it sounds this way, but like an approach of love, right? If I actually love the patients in front of me and I care about them as a human being, and I really want what's best for them, that's sort of the approach that I take of looking after these patients, right? And I recognize, hard though it is, like moment to moment, to recognize that they're the same as me. They've just, for whatever reason, been sucked into a whole world of misinformation that becomes their version of truth, right? It's the same thing that's happening in the States with Republican and Democrats. And and the fight, like there's this sort of taking of sides, and it doesn't make you a bad person because you just somehow ended up on the wrong side. So it's a systemic issue, and I approach it with love, and I try in relationships with my patients on a day-to-day basis so that hopefully one day they'll take my advice over whatever fear, whatever misinformation they've been fed.
Can I quickly tag on to that? Because I think this is so important. Kindness and compassion are not overrated. Kindness and compassion are more needed now than ever before. They are so, so important. And something that impresses me every day of all the healthcare people that I've met is how compassionate and patient they are and loving they are, even when people disagree with them, even when they're anti-vaxxers, even if they've participated in protests, just how warm and compassionate our healthcare workers still are and how professional they still are. It's incredible. It's really incredible.
Once again, we've reached our time, and so I'd like to once again thank our panelists for fantastic presentations and answering questions from the audience. And I'm going to turn the podium over to Anne once again. So thank you very much.
This has been an incredible evening. Al and I were saying to each other, every year we just think, well, how can we top that? And this has just been one of those spectacular nights for everybody who's been here. And I want to thank you, Danuta, Jesse, Matthew, Shannon. Thank you so much for sharing your wisdom with us tonight. It's been a wonderful evening. Thank you. If you would like to donate to the Lafayette Music and Health Legacy Fund, you see this is the money part because it was so great we got to ask for money now. Please go to the Lafayette String Quartet's website and use the link. The donations to this newly established fund will help support interdisciplinary research, teaching, and community outreach in the area of music and health. And we know how important music is for our health, the arts in general. Tomorrow, you will receive an email from the Lafayette Health Forum with a survey about your experience of this evening. Please complete it. Your feedback will help us plan future events, and hopefully next year it won't be COVID again. And you can find the evaluation form on our Lafayette Quartet website Health Awareness Forum page. So if you wouldn't mind filling that out, that would be really great for us too. We do take these very seriously in our follow-up meetings with our panel and the quartet are we go through every single person's suggestion and take them all really seriously and discuss each one. So please send them in. I want to just take, on a personal note, I want to thank my colleague Pam Highball-Loney, who is really, she's kind of like the tiger behind all of this, she just, thank you. We're her minions, she's running this thing. So thank you, Pam, for all your work, and Leah too. You two are just amazing. But we're going to close this evening with one more performance by the Lafayette String Quartet. It was recorded in 2020 when there were 8 good arms between us. In this little clip, we are playing an optimistic little scherzo by Beethoven. If there's an ominous middle section, it is very short-lived. Thanks to all our guests tonight and the marvelous questions that have come in, we can all feel assured that this time, too, will pass. And together we are navigating into more optimistic times.